Great, thank you guys very much. How many surgeons do we have in the office here, in the audience? A few, great.
Whoa,
We're
why did we invite
20 to
you
1.
guys? No, I'm kidding.
All right, here we go. So patient prosthesis mismatch, I think as surgeons, we've definitely learned with participating in TAVR, dealing with patients, the importance of PPM and making sure that we get an adequate size valve when we're offering surgery to patients. So it's definitely an important concept in both surgical aortic valve replacement and TAVR in the lifetime management of patients who are undergoing aortic valve replacement. Aortic root enlargement is a procedure that's been performed for decades to avoid patient prosthesis mismatch, but it's really underutilized. If you look at some of the data from the 2023 STS database yearly report, only 12.9% of patients undergoing surgical aortic valve replacement underwent a root enlargement. For the last several years, the Society of Thoracic Surgeons has put on a root enlargement course. Dr. Mike Reardon, one of my partners, and myself have been course directors for that, and we've really tried to get the message out of the importance of getting a large valve in for those patients to give them the best opportunity for that valve to last as long as it can. And we'll talk a little bit about that. So what exactly, first of all, constitutes a small annulus? So from a surgical perspective, you can only put in a 19 or a 21 millimeter valve. So remember, valves come from 19 to 29 in odd sizes. So if you can only put in a 19 or 21, that's a small annulus. If it has an area, now that we frequently get TAVR CTAs in all these patients and frequently are considering transcatheter therapies for them, if they have an annular area of less than 430 millimeters squared, it's considered a small annulus. We see this frequently in women. The most frequently implanted surgical valve in the United States is actually a 23 millimeter valve. And I'll make a provocative statement here. If you are sending your patients as cardiologists, if you're sending your patients out and they're coming back with a 19 or a 21 millimeter valve, that may not be the best long-term solution for those patients. Every patient, I really believe, should undergo a CT scan to evaluate the size of their annulus pre-op. You need to know and be able to speak with that patient beforehand and adequately consult with them about the need to do an aortic root enlargement. You don't want to get in there and find that the annulus is too small, put in some little teeny tiny valve, and they're back within 5 to 6 years with a valve that's developed structural valve degeneration. So I really think all patients should get a CT scan if you're thinking about surgical aortic valve replacement. So PPM, for our medical student group in the audience here, and including my son, when the calculated effective orifice area of the implanted prosthetic valve is essentially too small for the patients. And so the indexed EOA is defined as severe if it's less than 0.65, moderate if it's 0.65 to 0.85. We know that severe or even moderate PPM is associated with earlier structural valve degeneration, earlier reoperation in these patients, less LV mass regression, and overall decreased survival. And up to a third of patients in large surgical aortic valve series procedures performed in the US either come out with either moderate or severe PPM, which is crazy. If you look at this study, this is an older study published in 2018, the incidence and consequences of patient prosthesis mismatch after surgical aortic valve replacement. We see this is 59,000 patients greater than the age of 65 who underwent isolated surgical aortic valve replacement. Any degree of patient prosthesis mismatch would significantly decrease their long-term survival and increase readmission rates for both heart failure and reoperation for aortic valve replacement. In this study, PPM predicted structural valve degeneration in bioprosthetic valves out to just a short period of time. Right away, within 3 years, you start to see valves failing much earlier if they're associated with PPM. And in patients, structural valve degeneration, the risk factors for it would be female gender, smaller BSA, size less than or equal to 21, EOA less than 0.65, and any degree of PPM, either moderate, severe, decreased survival and decreased bioprosthetic valve degeneration in these patients. So when we decide on what size of valve that we're using in these patients as surgeons, we typically have sizers. You open up the aortic root, you cut out the leaflets, you debride all the calcium, and then you take your sizers and you see what type of valve you can safely get in there that's not going to obstruct the coronaries. And so if you have a patient that has a small annulus, the different companies, they all provide these charts of, green is good, yellow is questionable about their EOA, and red, you should try and do something else. Unfortunately, a lot of these charts have been shown to be kind of false advertising. You can measure these things on echo afterwards, but as a surgeon, you have to kind of figure out what size valve you're going to put in. Are you going to put the patient through a root enlargement at the time of surgery? And so one of the things that we've definitely learned is that these sizers that we use, that the actual size of the inner diameter of the prosthesis is 5 to 7 millimeters smaller than what it's really truly labeled as. Because remember, all of these things have a sewing skirt to them, they have a frame, and so the actual true inner diameter is much less. And so, the scary thing is you put a 19 or a 21 millimeter valve in someone, you're leaving them with a 14 millimeter opening. And so what are our different options as surgeons for the small aortic root? So there's been some classic root enlargement techniques, which we'll briefly talk about, the Nix, the Manugian. The Y annuloplasty we'll talk a lot about, and that's something that we've started over the last several years. We've done about 70 of them so far. And then conorastan's kind of a pediatric thing that you can do to really enlarge the left ventricular outflow tract. That's much more complicated, where you go through the right side, you actually split the septum, you put a double patch on the septum, and it's kind of a crazy thing that you do with a root replacement. Another thing that you can do for a small root is actually replace the whole entire root and then reimplant the coronaries higher. You place the valve superannular. If you really try and get a big valve in there, one of the things that can happen is that you really push on the right non-area, you're going to obstruct the electrical system, and the patient's going to end up with a pacemaker. We do have some rapid deployment valves, the Levanova Percival or the Edwards Intuity, and these have a minimal sewing skirt and a lower profile. And then as surgeons, many of us have learned to avoid using pledgets in the left ventricular outflow tract, which also take up space and increase the risk for patient prosthesis mismatch. So the Y annuloplasty is a technique that we've used over the last several years at Methodist, first described by one of our friends, Bo Yang, at the University of Michigan. And this really doesn't enlarge the LVOT, which is a downside of it, and it places the valve superannular, but you can actually get 3 to 5 valve sizes larger. And so what you do is, in this technique here, you're splitting the left sinus, you're going down to the annulus, you're actually going a little bit below the annulus, right to the anterior leaflet of the mitral valve there. You're then taking a left turn and going underneath the left main coronary artery and stopping short of that. Then you go a right turn and you go towards the membranous septum and stop short of that. And you essentially turn this thing into a quadrangle where you've then split it open here. We then take a large patch and are able to then sew this in and up the aortic walls on both sides. And then you take your sizers out, you put your sizer in place, you then mark where the tips of the sizers sit at the regular commissures there, but then you see where it sits along the Dacron graft that you put there, and we mark that, and then you put your valve stitches in as you would normally. You can take this patch, you can flip it over. We usually cut a triangle on the back side of the patch, and then actually take the ascending aorta and cut a similar size triangle on the back, which then fits just nicely to be able to enlarge the root here. And so you don't have to mess with the coronaries. As long as you stay away from the left, you're typically not going to have any coronary issues with this operation and technique. And so their group at Michigan at least has usually gotten a 27 or a 29 in most patients. We'll typically not get too crazy in terms of the large size of the patch. We'll at least get a 23 in a woman, 25 in a man. Usually we can get larger than that in most patients. And what we kind of tell the patients is that the larger size valve that we get in there, the lower the shear forces are going to be across that valve, the lower the gradient, the longer that valve is going to last for that patient. some of the older techniques, Manugian and the Nix, where you're splitting and going onto the anterior leaflet. With the Manugian, you can actually change the geometry of the anterior leaflet of the mitral valve and end up with mitral regurgitation. This technique avoids that because you stay higher up and not really getting into the mitral valve leaflet. So we do know that root enlargements are associated with increased bypass times, increased cross-clamp times, increased overall operative time. Some studies have shown no increased surgical mortalities. Others have shown a slight increased 30-day mortality risk. But you have to balance the short-term mortality risk. It's thought to be offset by the long-term mortality risk and reduction by avoiding patient prosthesis mismatch in these patients. And so this is one of the larger studies here looking at root enlargement 2008 to 2016. 2.9%. So again, every year there's more and more root enlargements that are being done to avoid PPM. Slight increased risk of 30-day mortality, 5.4% versus 3.4%. Once you get past 3 years when you follow these patients, the survival curves cross, suggesting that your survival benefit is when you avoid PPM in the long term in these patients. Thank you very much.
All right.